Hello everyone, this video is about wrist arthroscopy. Although it's a very rare topic for you guys, but it can be asked in a recent advances, it can come as a recent advances, and one needs to know because this is a very upcoming branch and you need to know what are the options. This is a complex procedures, but there is a role for it. So let's discuss about few basic things. What is the equipments required and what is the basic technique of the portals and what is the position. So going about wrist arthroscopy, so the basic OT setup will be on the, because a lot of these portals come on the dorsal side, many of the portals, because the critical structures are on this, especially the nerve and the artery on the volar side. So your portals are on this side. And this is a position what you keep, basically the armrest will be there. And this is important because the counter traction is from here. Traction and counter traction has to be acting. And this is a trolley, which you Mayo trolley, you keep it here so that you can keep the scopes and the shaver here. And your assistant will be here, the nurse will be here. If at all you want to, the rest all your scopy tower and everything will be in the opposite direction. So this is how it looks. This is the head end, the dorsum. The surgeon will be coming here for the procedure. And this is a type of traction system which is used. This is one of the earliest type of traction system which we were using. So there are a lot of modifications of this. So you can see this is called a Chinese finger trap. Basically, the more traction you give, it tries to grip the finger much better, and you need to. So you can increase the traction on this one as well. So here you can tighten it and slowly increase the traction. These hinges will give you more maneuverability and multiple angles. So you can tilt front, back, side, and increase the height as well. So multiple options are there. There are various types of traction towers which are available. This is another custom made traction tower. That was also a custom made. You can use a shoulder arthroscopy tower, and you can use a tower like this where the traction on the fingers can be made and you could start operating on the wrist. So this is how the shoulder tower there, and the counter traction will be there. So this is another traction tower where it is. So you can see in this image where you have a counter traction there, and you have a traction unit which gives you so much of it. It's a hydraulic system. You can see that you can just bend, and that's the clamp which I am pressing from my hand. When you press that, it moves. It allows you to get various type of, it's a hand positioner. You can use it for shoulder surgeries as well. So this is how it is helpful. And then attachment for that part you can get here on this side, where it will give you an attachment there, and that will give you a traction like that, which is again helpful. The final assembly will be something like this. So that's a sterile unit now. The hand is sterilized. You can get the axial traction. So there are various other companies which also provide. This is another counter traction provided here. And then the traction from above, you can suspend with weights. Generally the counter traction given is approximately 5 to 10 kilos of weight. This is another traction tower system by various companies, and this is the one which we also use it. Similar traction where you can increase the counter traction. Here you can calculate in terms of pounds of weight, how much weight you are using. That's the Chinese finger trap, and it is mentioned here, like calibration will be there, how much weight we are using. So essential instruments are marker pen and 18 gauge or 21 gauge needle, 5 ml syringe, and a grasper, punch, and a gravity flow of irrigation and RF ablator can be used. A tenotomy scissors like this is quite important because you generally don't have to, you'll have to be very careful when you're making a portals, or else you could cut the tendons. You can use various type of small arthroscopes. That commonly used for knee is around 4 to 4.5 mm is the common scope which is used for the knee and the shoulder, whereas here you use 1.9, 2.4, or rarely 2.7. And also you need a small joint shaver. So these equipments are a little bit slightly different. These are the portals of the wrist arthroscopy. So when you do, why these portals are, why are these named like this? So basically all these portals are named after the extensor in relation to the extensor compartment. So you have, these are the main three portals in the radiocarpal joint, and these are the other three portals on the midcarpal joint. And this is the Lister's tubercle, which is the landmark for all the procedures, where because you would are based on the reference of this is what you do the portals. So the first portal or the working portal is called the 3-4 portal. That means that portal is at the junction between the third compartment and fourth compartment. 4-5 is between the fourth and fifth compartment. 6R portal means radial to the sixth compartment, extensor compartment. And the midcarpal portal are MCR and MCU portal, and also EPL portal. EPL means STT portal with reference to EPL tendon. So 3-4 portal is generally 1 centimeter distal to the Lister's tubercle. It's a main portal of radiocarpal joint, and there is a main risk of damaging the EPL tendon while doing this portal, and it is the first portal of choice. And the 4-5 portal, this is the 4-5 portal is in line with the fourth metacarpal and slightly proximal to the 3-4 portal. The 6R portal, that is the radial to the ECU portal, that is 5 millimeter distal to the dorsal part of the TFCC. This is done under direct vision to prevent damage to the TFCC, and it is a main working portal. So one has to know, though finally, these are the radiocarpal portals here, and this is the midcarpal portals, and this one is the dorsal distal radioulnar joint, middle and distal, middle, and the proximal distal radioulnar joint portal. So making a portal, so this is again slightly different. You should not be plunging your knife into the joint because you could cut the tendon. So you feel the soft spot distal to the Lister's tubercle or the 3-4 metacarpal. Then place needle and just incise the skin only. And so after you incise the skin, you spread the tendons of the soft tissue and then introduce the artery. So this is how you do a portal. Basically, once you do this, so typically only incise the skin, don't plunge that much more, close the mosquito or the artery and enter the joint there. So once you give a traction, the joint space widens and you get some space to do this activity. And then you introduce the scope. So the irrigation will be gravity, and mind you hold the scope in this position, the light source is underneath and the camera will be sitting in the first web space. Unlike the other scopes where you hold the light source above. So this is, you're making the 6R portal under vision. The STT portal, the radial margin of the index metacarpal just ulnar to the EPL tendon is called the STT portal. And the entry angle, one should remember, it is not perpendicular like this. So it is as an obliquity. It goes, you enter the joint in an oblique direction. And the box concept described by Gregory Bain is what we generally use. So you can introduce this and you can see the joint in multiple angles like a box. Treat this as a box. And one should know the arthroscopic anatomy of the wrist so that you can identify so as soon as this is an important radioscaphocapitate ligament, and this is a vestigial ligament or the radioscapholunate ligament or the ligament of Testut. And this ligament is the radiolunotriquetral ligament. So these two, RSC and RLT ligament, are very strong ligaments which prevent the wrist from translation. Or also one can even have a simple OT record like this which has got an image, so you can easily mark whether, for example, if this is the TFCC, if you feel there was a tear here, you can draw a diagram and mention that it was a tear. And if you feel there's a central perforation, you can draw a diagram. It conveys more information than just writing pages together. So this image will be helpful if at all you are writing, and it's easy retrieval too. And if at all you do the same procedure, you complete a therapeutic procedure, you can write the details of the procedure. This is the image, that is the anatomic view because one should remember, even though Gregory Bain described this as a box concept. The wrist is not like a box, it's a curve. So your scope will get inside and you will see like this, not like this. So it is in this arc, both for the radiocarpal and also the midcarpal. So you generally tend to see like this. So this is the reference point for the various portals, and you can see this is a midcarpal. So this curve is even more steep compared to the radiocarpal portal. One should remember or follow certain principles or sequence of viewing each of these ligaments or cartilage, or else you generally will tend to. For example, when you see this image, you see that this image has got, or this imaginary creature has got 4 limbs. When you see from the front, you feel this imaginary creature has got 2 limbs. But when you see from the side, actually this limb has got 5 limbs. So the how you view matters a lot on deciding a lot of these stuff. So just follow some sequence which is useful to you, which you can easily reproduce. So radial side before the ulnar side, distal before the proximal, volar before the dorsal, ligaments before the articular surface, inspection before probing. And as I told, this gentleman was trying to take a photo of the Eiffel Tower just close at the base. So he really needs to hold the camera down to the earth to get the entire length of the Eiffel Tower. So that's where you see you don't hold the scope like this in the first image, you don't hold like that, you hold it like this in the second image, as the light source is in your hand and the camera rests on the first web space. One should also know about the other most common portals in the midcarpal joint: midcarpal ulnar portal, midcarpal radial portal. The depth of the midcarpal joint is less than half of that of the radiocarpal joint, and joint is tighter than this midcarpal joint is tighter than the radiocarpal joint. The MCR, or the midcarpal radial portal. So 1 centimeter distal to 3-4 portal in line with the radial margin of the third metacarpal. It is bounded radially by ECRB, ulnarly by the fourth compartment. It is one MCU portal is 1 to 1.5 centimeter above the 4-5 portal in the 4-corner intersection of the hamate, capitate, lunate and triquetrum, and this is in line with the fourth metacarpal soft spot, preferred portal for midcarpal joint. It is bounded radially by the EDC and ulnarly by the EDQ. So let's go to just a basic video on the wrist arthroscopy video. So this is, you are seeing the radiocarpal joint and viewing through the 3-4 portal. So the minute you see introduced, that's the RSC, and the scaphoid is at 1 to 2. That's a long radiolunate ligament. After that, you will have a short radiolunate ligament. Further ulnarwards, moving towards ulnarwards, you can see that's a ligament of Testut, or the scapholunate ligament, RS. It's a vestigial ligament. And further going ulnarwards, you can see the TFCC, the ulnotriquetral and the ulnolunate ligament also. Now this is the scapholunate interosseous ligament, what you are seeing around the 9 o'clock position. That's a scapholunate interosseous ligament. Once you have seen, then that's the lunate. And going towards ulnar side, that is the TFCC again. That's a dorsal capsule which you are seeing on the dorsal aspect of the dorsal between the and you are making the 6R portal through that. So the TFCC is inferiorly. That needle is just 6R portal. We are trying to establish through that. Introduce a mosquito, then you use a probe. Feel for the TFCC, whether how the trampoline effect is there. The foveal attachment of this TFCC is quite good. Next, coming to the midcarpal, you are throwing view through the midcarpal portal and the diagnostic portal. So this is, as I told, this is a much tighter portal and the shorter depth as well. So as soon as you introduce, what you see is the lunate, then that is a scapholunate interval. Then moving ulnawards, that is the lunotriquetral interment, that's the lunate and the LT interval. Going towards further capitate on top, you can see, and that's the scaphoid. You are tracing it distally along the distal pole, and that is the trapezium and the trapezoid. So let's look at the indications. So diagnostic, even though the MRI is there, this is still considered as a gold standard for diagnosing a lot of conditions, like unlike other pathologies of the knee or the MRI. And it is commonly used for synovectomies, loose body removal, ligament injuries when you want to repair scapholunate or LT injuries or even reconstruct them, TFCC injuries, scaphoid fractures and non-unions. Distal radius fractures also can be managed. Partial wrist fusion or carpal fusion and Kienbock's. So these are some of the common conditions which can be used, and these indications are progressively increasing as the skill of the surgeon goes on improving. The final message is you need to know the anatomy and what are the equipments, because these equipments are quite special equipments and the training requirement is quite extensive. And the complications. So some of the complications are mainly you could injure the tendons, you could injure the cutaneous nerves, and that could lead to a significant disability. So it has to be done under supervision, and would suggest not to venture into it without a appropriate training. Thank you very much.